internal medicine at the University of Rochester in New York with the American Board of Internal Medicine, and he had a fellowship in pulmonary and critical care sleep medicine at Cleveland Foundation with an American board in pulmonary critical care and sleep medicine, and he is assistant professor clinical medicine at University of Balmain, staff of pulmonary and critical care medicine at St. George Hospital University Medical Center since 2004, and he's head for sleep center at St. George Hospital University Medical Center. Dr. Juvelikian, votre présentation.
Thank you, Dr. Khouri. Good morning, everyone. First, I want to thank the organizing committee and the scientific committee for the privilege of presenting at the Congress. Actually, I took the liberty of modifying a little bit the content of the presentation because as I was going through it, I discovered two things. It's a very easy topic because there isn't that much there in terms of information published, that is. And it's a very difficult topic because there isn't that much there in terms of presenting information. I tried to focus a little bit on pneumocystis as we see it today, mostly in the non-HIV population, because I think as pulmonologists, especially in countries where the prevalence of HIV is not as high as in some other countries, the major bulk of pneumocystis is probably going to end up in different populations than we were accustomed to in the 80s upon the HIV era. And I think that as I was going through the preparations, I discovered that I had a lot to learn about when to suspect pneumocystis, why that would be important, and which populations, growing populations, I would say, would be important for us to consider that possibility, especially when faced with trouble. And I will also add that probably similar to what Dr. Ben Khadr was saying about tuberculosis, in terms of pneumocystis, prevention appears to be much more important than the treatment of the condition once it's sets there. This is a quick outline of what I'm going to go through. I'm going to focus more on some areas more than others, but I will talk about the epidemiology and a word on the pathophysiology of the condition, the usual clinical presentations, how do we establish the diagnosis, and then management, mostly prophylaxis, and then a word on treatment. As you know, the name was changed a few years ago from pneumocystis carini to pneumocystis girovecii or girovecii. And that's for a reason that has to do with species specific. It turns out that the carini was more specific to rats, and maybe that's why we had to maybe change it to more of the human, if you will, species, because it is species specific and because it turns out that pneumocystis is not really jump species, at least not yet, thank God. Infection is apparently quite ubiquitous. In other words, by age 3 in some of the studies, most of us will have antibodies against pneumocystis. So it's everywhere, and we seem to get it and not even know about it, and hopefully never will need to know about it during our lifetime. It was quite prevalent in the 80s. It remains quite prevalent in the HIV population, especially when the CD4 lymphocyte count drops below 200. In non-HIV positive patients, it's not so prevalent, but the prevalence is increasing. And there are certain populations that appear to be at risk. Chronic steroid use, and we are all aware in the pulmonary community that without steroids, probably half of what we do will become not manageable, except that the population of patients who are requiring steroids is actually growing more and more. So chronic steroid use in immunocompromised individuals, and I will emphasize the word immunocompromised later on as we discuss that point in a bit more detail. Cancer patients, transplant patients. In Lebanon, we don't have that many transplant patients, but it is a growing population as the program is actually gaining more momentum. The mode of transmission is still debated, and that's because, as I mentioned a minute ago, that infection appears to be, or at least exposure, appears to be quite ubiquitous in terms that we have antibodies present in our systems, almost all of us, by age 3. So is it reactivation of a latent infection like we see in TB, for example, or is it de novo acquisition? And we have data that supports both ends of the spectrum. Just like the name was changed, also only a few years back, in 1988, was it established as a fungus, not a protozoan as previously thought. And that's because of many different pieces of data that were gathered. Again, it turns out that pneumocystis is very difficult to grow in vitro. And so most of the studies are done in organisms that would be infected. So through ribosomal RNA gene sequencing, cell wall structure details, and structure of some key enzymes, the establishment of the organism as a fungus has been established since 1988. We knew about it years before in infants and children who were malnourished following the Second World War. In the 60s and 70s, we started seeing it in hematologic malignancies. And of course, in the 80s, it became almost known to everybody because of the HIV epidemic. Again, with the proper prophylaxis in the HIV population, the prevalence was reduced tremendously, but it is still the most important population. In non-HIV, like I said, it appears to be increasing as incidence. We have higher numbers of people who are immunocompromised, who are surviving for longer periods of time because of the better access to care, more complicated regimens, and better intensive care available in most nations. Transplant patients are, I think, a population that is an important part of that non-HIV PCP population. The increasing use of glucocorticoids with the presence of immunocompromised state or comorbidities is also a key factor. And cancer patients, be it solid and hematologic, appears to be also an important population in the non-HIV section. One of the studies that was done in 1996 at the Mayo Clinic looked at 116 patients who were infected with PCP, and 105 of those had actually corticosteroid use with a median dose of 30 milligrams carried over a period of 12 weeks. Like I said, the hematologic cancers appear to be more likely to be risk factors for PCP acquisition and disease than solid cancers, and especially when we use chemotherapeutic agents that cause marked lymphopenia, such as the purine analogs. Organ transplant recipients, with the prevalence and increasing centers doing transplants all over the world, is the growing population, and it was the second most common group in the Mayo series mentioned above. In HIV, like I said, the CD4 count less than 200 appears to be a major reason for concern with PCP risk factor. In the non-HIV population, glucocorticoid use, like I said, in the presence of other causes of immune suppression is the main risk factor. And that seems to be, the mechanism seems to be suppression of cell-mediated immunity and alterations in lung surfactant. These two appear to be elements that are important in the acquisition and development of disease with pneumocystis. Interestingly, and I think this is something that we are maybe and not paying much attention to, because we do use quite a bit of steroids in our asthmatic population. Now, these patients do not seem to be at risk for PCP, and it turns out that probably the theory today is that these patients do not have other conditions, other reasons for immune suppression or for lymphopenia or for affection of their lymphocytes that would make them more prone to developing PCP. So if you look at the literature, and especially the asthmatic literature and the incidence of PCP, you will only find probably case reports or maybe case series at best, not more than that. And that may be why we are not accustomed to thinking about maybe PCP when we use steroids, especially at higher dosage, more than 30 milligrams a day. In rheumatologic diseases, the prevalence appears to be worse in dermatomyositis and polymyositis compared to other conditions, say SLE, and that seems to be related as well to the presence of lymphopenia and idiopathic pulmonary fibrosis development. How do people present with pneumocystis? Well, fever, non-productive cough, and dyspnea on exertion. Interestingly, if the patient actually has purulent production or pleuritic component, most of those patients do not turn out to have pneumocystis and appear to have just your regular garden variety pneumonia or from other conditions. Lung auscultation may be normal or may reveal crackles, which usually portends a worse outcome. This is a typical presentation of a chest X-ray in a patient that may be affected with pneumocystis. So it is perihilar, bilateral, reticulonodular infiltrates that seem to be symmetrical and that seem to be spreading. And the worse the spread, the worse the outcome usually. But that's not the sole presenting feature of pneumocystis. These patients seem to be at risk of developing pneumatoceles. These do not really project very well, I don't think, but if you can imagine with me, you'll find three of them where the arrows are. That makes it kind of easy, I guess. And pneumatoceles are one of the reasons for which in HIV, especially patients with PCP, they have difficulty sealing their pneumothoraces once they open into the pleural space, and they require the intervention of a thoracic surgeon if we're lucky and the patient survives. You can have pictures similar to ARDS, and that becomes one of the differentials that we need to probably become more accustomed to thinking about when we deal with patients under the categories I mentioned, that is chronic steroid use for whichever reason with comorbidities. But sometimes it may be just similar to what you would see with a pneumonia, with consolidations and air bronchograms and the usual features. What do we see if we do a pulmonary function test on those patients? Usually you see restriction, and if you were to check a diffusing lung capacity from carbon monoxide, you will find that that is quite affected, and that makes sense because it's mostly reticulonodular infiltrates with reticular formations. That's why high-resolution CT scans appear to be a good way of maybe sorting out patients that may be more at risk. And a typical presenting finding on the high-resolution CT scan would be patchy areas of ground glass attenuation in which vessels are seen and a background of interlobular septal thickening, which portends 100% sensitivity and 89% specificity in a study that was done a few years back. Of course, visualization of the organism in both its forms is diagnostic, and that's done through a bronchoalveolar lavage if you have that possibility, and it's a very quick test to do. And the beauty of it is that if it's negative, it essentially rules out the diagnosis. You don't have to do a BAL. You can do a deep tracheal aspirate or induced sputum, and that would also be quite helpful if scoping is not something that is quite prevalent and available in your institution. And you can see them with different stains. There are multiple stains that can help establish the diagnosis of PCP. So you can have the silver stain, the methenamine silver stain. Giemsa stain can help. There is a toluidine blue O stain, and also a diff-quick stain. I'm not sure really at our institution. I think we use the silver stain, but I'm not sure if you use other stains as well. It is good, important to have a good laboratory to check on those, because if it's done properly, it will give you the answer at least about the presence of PCP. So like I said, depending on the stains used, including a fluorescent stain, you can have your diagnosis. Prophylaxis, I believe, is very important and is probably key. If we can prevent the development of PCP, the battle is essentially won, because the outcome, despite proper treatment, continues to be, grim, if at all. Prophylaxis is highly effective. It is quite safe. It's quite simple. It's recommended in patients receiving more than 20 milligrams of prednisone for 1 month or longer, or who also have, of course, like I said repeatedly, other causes for immune suppression. So patient with hematologic cancer requiring stem cell transplantation, a patient with Wegener's, for example, on cyclophosphamide and glucocorticoids, and like I said, dermatomyositis, polymyositis in the rheumatologic population with IPF and lymphopenia and other conditions that you would be familiar with immediately. In the meta-analysis that was done from the Mayo Clinic proceedings, treatment with trimethoprim sulfamethoxazole Bactrim essentially was effective and quite cost-effective. Out of 1,245 patients who were pooled, 91% reduction in the occurrence of PCP in patients receiving prophylaxis, and the mortality was reduced, but not all-cause mortality. And this is a borrowed slide on the prophylactic regimens. Some patients have a problem with the medication. They are allergic to Bactrim and they cannot use that medication. There are other alternatives. Quite effective pentamidine is an important alternative, aerosolized. The problem with pentamidine, I will touch on that, I guess, later on, but the problem is that it does seem to deposit less swell in the upper lobes. So what happens is that sometimes we can have recurrence of patients, and what we need to pay attention to is that in those populations, you will have a preponderance of infiltrates in the upper lobes, because this is where the medication does not really deposit well, and we need to pay attention to that if the distribution appears to be a bit atypical. Dapsone and atovaquone are other possible prophylactic measures that are also quite effective. Those medications carry their batch of side effects, the most important of which are, of course, rash and maybe liver function disturbances and blood dyscrasias. But like I said, trimethoprim sulfamethoxazole remains the treatment of choice because it's well tolerated, it's a very cheap medication, it's effective, and it's got, I'm sorry? Minimal side effects. Pentamidine, like I said, is effective. It is associated with more side effects, including increased urea, creatinine, glucose, and local effects, and does not deposit well in the upper lobes, as I mentioned. Well, what drugs do we use for the treatment of pneumocystis? Well, the drugs are actually the same. The difference is in the dosages and the duration of therapy. In the HIV population, the treatment is for 21 days. The data are flimsier and less prevalent in the non-HIV population, but there seems to be a consensus for a similar duration of treatment of 21 days, essentially. Like I said, trimethoprim sulfamethoxazole remains the preferred regimen for treatment, and the dosages is quite well known. And alternative treatment options include, again, pentamidine, atovaquone, trimethoprim and dapsone, and primaquine and clindamycin as well. In mild to moderate pneumocystis, alternatives appear to be atovaquone, 750 milligrams BID can be used and quite effective. The duration, like I said, is debatable. Even if the patient seems to do quite well, it is preferable to continue treatment for a duration of 3 weeks. Other regimens, also in the mild to moderate pneumocystis infection, includes clindamycin and primaquine and trimethoprim plus dapsone. Patient, of course, should be tested for G6PD deficiency to prevent hemolysis. How patients with severe pneumocystis are a bit different because, as you know, in the HIV population, there are certain criteria that would get you to use steroids as adjunctive treatments with the treatment for the PCP. So if you would say use your trimethoprim sulfamethoxazole, adding steroids in the severe cases is used, and that is usually when you have a PaO2 that's below 70 or a gradient that is greater than 35 millimeters of mercury. The severity of PCP in patients who do not have a contraindication, they should be on trimethoprim, and that was found to be the most efficacious regimen to date. From multiple studies, I only quoted one of them, and that's an old study. There is greater toxicity in patients who are more severe with the infection. Clindamycin and primaquine may be used as an alternative regimen in patients with severe pneumocystis who have failed trimethoprim or intravenous pentamidine. And the cyst wall of PCP, as you know, now that it is actually a fungus, does appear, at least in theory, to be susceptible or should be susceptible to echinocandins. However, unfortunately, in studies so far, although they are limited, the benefit appears to be very limited and not very satisfactory. So until today, we cannot really recommend the use of echinocandins in the treatment as part of the regimen for the treatment of pneumocystis pneumonia. Like I said, in contrast to HIV positive patients where steroids appears to be helpful as adjunctive treatments for severe cases and with a gradient of more than 35 millimeters of mercury or a PO2 that is below 70, the data are less convincing in the non-HIV population, but we still carry the same recommendation until proven otherwise from future studies.
Dr. George,
yes.
1 minute.
I will be done. Retrospective study from the Beth Israel Hospital in Boston actually revealed no change in the intubation or mortality with high or low tapering steroids. However, it did show that when you use high doses of glucocorticoids, you have shorter need for mechanical ventilation and shorter ICU stay and need for supplemental oxygen. So it does seem to improve the gas exchange, but unfortunately not the mortality. And a similar outcome was actually seen in another study a bit more recent in clinics of infectious disease. However, neither study was well equipped because of their size to answer that question. The outcome without treatment, 90 to 100% mortality in the non-HIV populations. In the non-HIV populations, the mortality with adequate treatment is also worse than the mortality in HIV populations. And that seems to be related to the immune reaction of the patients to the infection itself, rather than the bugs themselves. The degree of inflammation appears to play a major role. The patients with HIV appear to have more organisms in their BAL, but less neutrophils. The opposite is seen in patients with non-HIV PCP. So a quick roundabout on the treatments, and you will see from the grade of the recommendation that none of them actually is your best grade that you would want in a recommendation. Bactrim remains the preferred medication for the treatment of PCP in patients without HIV. Mild to moderate atovaquone may be an alternative that is appropriate. Other drugs for moderate and mild PCP are clindamycin and primaquine, with trimethoprim and dapsone as alternatives as well. In patients with severe pneumocystis who are unable to tolerate trimethoprim sulfamethoxazole, intravenous pentamidine is recommended, and adjunctive corticosteroids in non-HIV PCP appears to be similar to the HIV population. And finally, pneumocystis remains a serious and deadly opportunistic infection. We should be more vigilant in considering it, especially in non-HIV patients with the growing population of patients susceptible to that organism nowadays. Prophylaxis is, in my opinion, much more important than treatment once the condition sets in, because the mortality remains extremely high. Treatments are available for the treatments available, the most effective of which remains trimethoprim sulfamethoxazole, and despite appropriate and timely intervention, mortality remains very high and higher in non-HIV than in HIV population. And I thank you for your attention.
Thank you, Dr. Juvelikian, for this very interesting